This presentation reviews basic anatomy and physiology of the heart. The heart is located in the thoracic cage, primarily on the left side. Note that the base of the heart is located superiorly, while the apex is located more inferiorly. Also note that the heart is somewhat twisted so that the anterior portion of the heart, as is shown in the frontal plane here, is mostly comprised of the right atrium and right ventricle. Also note the location of the aortic and the pulmonic valves. The aortic valve is located primarily on the right side of the sternum, while the pulmonic valve is located more on the left side of the sternum. Also note that the best place to auscultate the mitral valve would be over the fifth intercostal space. This schematic just shows the pericardial sac within which the heart sits, as well as the muscle layers of the heart. So let's consider first the pericardial sac. The outermost portion of this sac is called the fibrous pericardium, and it is made of very dense connective tissue. The inner layer of the sac actually has two layers. The inner layer is called the serous pericardium, and it is comprised of the outermost parietal layer and the innermost visceral layer, which actually comprises the outermost layer of the heart muscle itself. So when we move on down and just look at the heart muscle, we have three layers. The outermost epicardium, which is also the visceral layer of the serous pericardium, then the middle myocardium, and then the deepest part of the heart that is continuous with the heart valves itself is the endocardium. This slide just shows the pericardial layers that we just discussed. You have the outermost pericardial sac, which is very, very dense fibrous tissue. And then you also have the serous pericardium that has two layers, the parietal layer and the visceral layer. This schematic just helps us to further visualize the pericardium. Shown here as a balloon is an example of the serous pericardium with its outermost parietal layer and innermost visceral layer, which, as we said previously, forms the epicardium, or the outermost layer of the heart. This serous pericardium actually sits inside of the fibrous pericardium. One reason we need to even talk about the pericardial sacs has to do with its relationship to pathology. As we stated previously, this fibrous pericardium is very, very dense, and it firmly holds the heart within the mediastinum of the thoracic cavity. The serous pericardium, with its two layers, forms a pericardial cavity. In the case of inflammation, this pericardial cavity can fill up with fluid in between the parietal and visceral layers of the serous pericardium. With inflammation, this fluid increases and squeezes the heart, restricting its action. Pericarditis can result from viral, bacterial, or fungal infections, or from an injury or surgery. An advancement of pericarditis is called cardiac tamponade, and this is a life-threatening condition. When excessive fluid forms in the pericardial sac, enough pressure may prevent the heart from relaxing completely between beats. This pressure will prevent complete filling of the heart before the next heartbeat, and this lessens the amount of blood that can be pumped out by the heart, thus reducing cardiac output. So severe pericardial fluid pressure can cause a severe drop in blood pressure, shock, abnormal heart rhythms, and even death. This schematic demonstrates the relationship between the fibrous pericardium, the two layers of the serous pericardium, and then the muscle layers of the heart. Note that the coronary arteries and veins lie within the visceral layer of the serous pericardium. That is, these main blood vessels lie actually outside of the heart myocardium, and then little extensions from these major arteries will extend down into the myocardium to supply the heart muscle itself with blood. So you can see here that the named coronary arteries that we'll talk about in just a moment actually lie within the fat of the visceral layer of the pericardium. That is, they lie within the epicardium, and then send little subendocardial branches into the actual heart muscle itself, or the myocardium. So before we talk about blood flow to the heart muscle itself, let's talk about general blood flow through the heart. The heart is comprised of 4 major chambers, and blood is received from the body into the right atrium through the superior and inferior vena cava. After coming into the right atrium, blood flows through the tricuspid valve into the right ventricle. From there, blood flows through the pulmonic valve into the pulmonary artery and out to the lungs, where the blood is then oxygenated. The blood then returns to the heart through the pulmonary veins into the left atrium. Blood passes through the mitral valve into the left ventricle, and then exits through the aortic valve into the aortic artery, and then is distributed out to the system. It is important to note that all blood vessels, whether you're referring to arteries or veins, are comprised of 3 major layers. They are the innermost tunica intima, the middle tunica media, and the outermost tunica adventitia. The tunica intima has endothelial cells and subendothelial connective tissue. The tunica media is comprised primarily of smooth muscle cells, but also has elastin and collagen. The tunica adventitia is comprised of collagen and elastin fibers, and then it also has nutrient blood vessels that actually come back to supply the blood vessel itself. This schematic just shows the differences between the arteries and veins. Note that the arteries, which are shown here in red and on the left side of the picture, have all 3 layers of tunica intima, media, and adventitia. Note that the tunica media, or the smooth muscle portion, is quite a bit larger than it is in the veins. Note that in the veins, again, you have all 3 layers, but the veins tend to be thin and floppy. Thus, the arteries are intended to operate under high pressure, and the veins are intended to operate under low pressure. So now let's discuss the actual blood supply to the heart itself. Note that the 2 main arteries that supply the heart actually branch off of the aorta just beyond the aortic valve. You can see the right coronary artery courses down the right side of the heart between the atria and the ventricle, and then the left coronary artery is a very, very short artery that extends from the left cusp of the aorta and goes a very short distance towards the left side of the heart. From there, the left coronary artery will branch into the anterior interventricular artery, also known as the left anterior descending artery, and then also branch into the circumflex artery. So the left coronary artery will divide into the left anterior descending artery and the circumflex artery. This slide just shows the areas of the heart that the right and left coronary arteries and their branches supply. The right coronary artery gives off a branch, the right marginal. In some cases, the right coronary artery will then wrap around to the posterior aspect of the heart and form the posterior descending artery. The right coronary artery will supply the right atrium and will provide some blood supply to the right ventricle. The right coronary artery also provides blood supply to the AV node and to the SA node. The left coronary artery will divide into the left circumflex and then into the left anterior descending artery. The left circumflex branch will provide blood supply to the left atrium and part of the left ventricle, and the left anterior descending artery will provide most of the blood supply to the left ventricle, as well as some blood supply to the interventricular septum and part of the right ventricle, and in some cases will provide some blood supply to the SA node. Note that the left circumflex artery may form the posterior descending artery instead of the right coronary artery forming that posterior descending artery. This really is not of huge functional significance to the physical therapist, whether the right coronary artery or the left circumflex artery actually forms the posterior descending artery. But it is important to note that the posterior descending artery does provide blood supply to the posterior aspect of the interventricular septum and also to the inferior portion of the left ventricle. So the reason to even study the coronary arteries and the portions of the heart that they supply has to do with cases in which there is a blockage of these arteries, which can then lead to myocardial ischemia or lack of blood flow, or infarction or actual death to the heart tissue itself. Note here in this diagram labeled number 1, you can see that there's an area here of the heart that is not getting good blood supply because of the blockage in the coronary artery that's depicted here by the number 2. Anytime there is a blockage to a coronary artery, then the portion of the heart distal to that blockage that is supplied by the artery that's blocked will become ischemic or will actually die. In addition to the actual blood supply to the heart, we have to consider the pressures under which the heart is accustomed to operating. Note that the right side of the heart is accustomed to operating under very, very low pressure. If you look at the chart here, you can see that the actual arterial pressure in the superior and inferior vena cava and then backwards to the veins and capillaries is very, very low. That means that the right side of the heart is accustomed to operating under very, very low pressure. The left side of the heart actually generates a lot of pressure as it needs to pump blood out into the aorta and out into the systemic circulation. So the left heart is accustomed to operating under very high pressure, and the right side of the heart is accustomed to operating under very, very low pressure. So let's think about some conditions in which the right and left heart might be challenged to work, given the fact that the right heart is intended to function under low pressure and the left side of the heart is intended to function under high pressure. Well, suppose that there's some kind of a lung problem that causes the lungs to offer a lot of resistance to blood flow. The right heart is not made to function under high pressures, but in the case of high pressures in the lungs, the right heart would be forced to have to generate enough pressure in order to try to force blood through these compromised lungs. That condition could lead to an overworking of the right side of the heart or right-sided heart failure, also called cor pulmonale. Let's talk about the left side of the heart. In some cases, the aortic valve may become very stenosed or very tight, very difficult for blood to exit through the aortic valve. In this case, the left ventricle would have to generate a tremendous amount of pressure in order to pump blood out of itself. That is, for the left ventricle to generate enough pressure to overcome the pressure in the aortic valve in order for blood to exit the left ventricle. In this case, the left ventricle may become overworked and may start to fail. This can cause left-sided heart failure. This failure of the left side of the heart to work very well can lead to a backup of pressure into the left atrium and then eventually into the lungs. So this left-sided heart failure may eventually cause a backup of pressure into the lungs, which can then cause the right side of the heart to fail. So you can see that it's important that we understand these right and left-sided heart pressures so that we can understand what happens in the case when these pressures are altered and requires the heart to work a lot harder or in a different way than it is accustomed to working. So now let's think about why it's important that the physical therapist even study all of this. What role can the physical therapist play in preventing or treating this primary pathology that leads to blockage of the coronary arteries? That pathology would be the process of atherosclerosis. We also have to consider the surgical procedures that may be used to help open up the vessels and keep them open, or to totally bypass a blocked coronary vessel. Under what conditions would one surgery be preferred over another? And then what are the considerations for the physical therapist after that surgery has been performed on a patient? We also need to think about the clinical manifestations of right or left heart failure. What would that look like, and what role can we play in helping to initially diagnose this problem or to assess the progression of the problem? And then lastly, we need to think in general, what can the physical therapist do to help prevent heart problems and also treat patients who have heart problems? We'll be considering these questions in our future discussions.